I have to give the caveat. I am a behavior analyst, but for today's webinar, I am going to be giving some perspective of the health plans. And one of the things that I think is important is to kind of give a small disclaimer that I live, eat, breathe, sleep behavior analysis. I am a strong believer in its application across multiple areas. But I also know that in my public policy work, one of the best ways to advocate for services for our consumers is to understand kind of our competitors or our threats and what their perspective is. And so I did go in and get my doctorate in behavioral health with an emphasis in integrated healthcare management with the idea of learning about health plans. I felt that it was extremely important perspective for us to have as we continue to navigate the insurance world. I'm not going to read these out entirely, but just so you guys have an idea of what we'll be going over today. And again, kind of talking about the health plan perspective as a priority for today. I do have subsequent webinars that I can put on or answer questions towards more of the role of the clinician in the health plan or the clinician in the medical necessity realm. But I like to start off with the health plan's perspective because it kind of gives us that starting off point of understanding where these kind of pushbacks are coming from in our field. I also like to explain that a lot of this perspective is not specific to behavior analysis. This perspective is just how the health plans operate in all facets of the work that they do. So it's in dental plans, it's in medical plans, it's in behavioral health plans, it's in any integrated plans. It's not behavior analysis specific. And I think that that's an important perspective for us to have. All right, so what is medical necessity? You know, I have found over the years that medical necessity has kind of been a trigger word for everybody. It's trigger for, from a legal sense of when it's medically necessary, people want to go to bat in public policy. They want to go to bat in getting civil rights concerns addressed. And there's a huge kind of trigger in the legal process. Medical necessity is a process in the health plans. And so there's this perspective in the health plans regarding medical necessity as to whether they can or cannot cover services. And understanding that health plans do receive money from various sources, many of them, while they are commercial plans do receive private funding, a lot of them are still largely regulated by the federal and state governments and by the Centers for Medicaid and Medicare Services. And so keeping in mind that there's two parts to kind of the medical necessity perspective of healthcare. And one is that they do have to be able to pay the bills of what they're promising to cover. And with recent legislation, especially legislation after the Affordable Care Act, they are expected to only cover services that are evidence-based. And so there's a lot of controversy within the health plans and across the health plans as to how that need gets met. We have, of course, medical necessity from the perspective of our own best practice standards. One thing to keep in mind with medical necessity and kind of the playing field. So like I said, I'm talking about it right now as a trigger word. I'm going to dive into more of what it means in a little bit. But when we talk about it as kind of a trigger word, we're looking at its use in treating a medical condition. But one of the things that I have found in the professional practice is sometimes medical necessity is a general term for autism services or ABA services for autism coverage. And one of the problems that we run into with that is that medical necessity has several components built into it that we still have to justify as a field, but also on an individual basis as clinicians. Medical necessity doesn't just affect behavior analysis. Medical necessity concerns are evident in other professions, including our colleagues in speech and occupational therapy. You know, just to give you an idea of some of the clinician concerns around understanding medical necessity, especially in autism treatment, is speech pathologist and the research that supports intensive services for young children with apraxia. What you'll find is many of the health plans cap those speech services as being, 1 hour a week or 2 hours a week, and that becomes problematic in what is evidence-based for young children that do exhibit signs and symptoms of apraxia. So again, just giving that perspective of it's not just about behavior analysis. We have other fields, our own colleagues that are having to kind of navigate this healthcare world. And I think in behavior analysis, one of the things that we we have to remember is that, we started out of an academic setting, moving into kind of a sub-academic clinic research type setting, and then into the educational world. So the health plan coverage of ABA is still fairly new. There's been legislation to cover health plans or for autism treatment for about 13 years now, with the exception of the Department of Defense pilot program. Their TRICARE's pilot program, I think, has been around about 14 or 15 years now. But other than that, the health plans are still fairly new in covering our services, whereas our other colleagues have been getting services covered for 10, 20, 30 years plus. And so keeping in mind that the equivalency of what's covered in the academic realm and what's considered medical necessity are two very different things. So we're kind of in this uphill battle. And I have another webinar that I talk about kind of our need to bring our supervisees and our students into this medical world, because the more that we continue to train in kind of the mindset of the academic and the educational world, we're missing this big gap in the medical world. And then when we do get to the medical world, understanding everything is evidence-based and what we know about experimental behavior analysis, research, the quality of the research that we do have, the intent and the meaning of the research designs that we have, keeping the integrity of those as we move forward in the autism treatment. And one of the things that I hear often as a university professor, I teach research methods, and many of the students at the onset of courses will tell me, I'm only taking this class because it's a requirement. I work in an ABA agency, we provide services to autism. I don't need to know this stuff. And I'll tell you that in learning to navigate medical necessity, you do need to know it, you do need to understand it, and you do need to know how to interpret the research in a way that allows for you to advocate for your clients. And then we have the patient perspective of medical necessity. And this one's a little bit more complex, and it's largely influenced by historical factors. And so you'll see patients of young children seeking services that want to remediate the symptoms of autism, want to treat the symptoms of autism. And then as they start to age, sometimes the perspective of the families is more of a relief or a respite care. And that's important for us to think about as we start to navigate what truly is medical necessity. All of these components have to play into kind of our perception of medical necessity and do help us guide our processes in working with the insurance plans. So what is the role of the insurance plan? Well, they have kind of a big task afforded to them, and that is to actually develop guidelines around medical necessity. What is the criteria? What is the coverage policies? What are they willing to pay for? How much are they willing to pay for? And this is all done long before services begin. And these are oftentimes, and the reason why I call them guidelines is because these coverage policies are kind of that first layer of approval. That is that first, any reviewer can kind of approve at this bare minimum without further process. And there's a lot of reasons why this has to happen. One is so that we prevent abuse of the system. So again, a lot of these plans are working in the realm of Center for Medicaid and Medicare, which means some portion of the dollars is coming from our tax dollars. And so abuse of the system is of concern to health plans, and it should be. I mean, we're seeing it of concern of our own colleagues, and so it should be a continued thought process that we are including in our understanding of the health plans, is that there has to be some way for them to regulate and prevent abuse. And this is kind of that first layer, to develop guidelines that say, hey, these are the things that we are able to cover. We support the evidence in these. We have the research that supports them, and they kind of cut it there. Now, if you're interested in going above and beyond those guidelines, there's the appeal processes. And the appeal processes can be frustrating and they can be intimidating. I will tell you, in all of the appeals that I've assisted with, one of the kind of glaring concerns that I continue to see is that the clinicians filing the appeals have never even read the original medical necessity guidelines. And so if you're going to file an appeal, keep in mind that that is your secondary layer. So that's basically you saying, hey, I have reason to disagree with these guidelines, and I need to come forth and present my data, present my facts, present my research, present my cost efficiency. And so if you haven't even read those basic guidelines, then that appeal process becomes very challenging. What I'm going to talk about right now is those basic guidelines. So that is, again, that kind of coverage piece. Now, most people don't know, but that basic guideline is what also allows for medical plans to stratify their client base and to develop rates. So valuing codes comes from both understanding the client population that you're going to serve, so your need, the available funds, those sorts of things, lining that up with the best available research that's available. So you now have an understanding of your client base, you have an understanding of the research based on age, diagnosis, et cetera, of what each client under that general medical policy is going to need. And then you have historical billing, and those three things kind of come together in value setting the codes. One of the things that we run into, and some states are seeing it now, is that without CMS valuing the current codes that we have, the health plans are having to value the codes, and a lot of people are kind of frustrated with that process. And there's reasons to be, and I'm not trying to dismiss that. Again, today I'm kind of thinking of a little bit more of the health plan perspective. I definitely can follow up with the controversy of where we are seeing those concerns. But without having those kind of guidelines, they can't budget and they can't present financial justification. And so these guidelines actually do allow for them to establish what their financial burden as the organization is going to be. Now, there's other sides to that. So please know that I am fully aware that how we define financial burden and how a health plan may define financial burden may be two very different things. But again, keeping in mind that with having an understanding of your population base and what the needs are going to be and having those basic guidelines, it's very difficult to budget for the future. All right, so what goes into these policies? Well, the biggest components that they have to disclose in their policies, so they have to do research on all of these, is the disease burden, any of the interests, both public and provider. So what is the public interest in the coverage? What is the provider interest in the coverage? Any controversy. So what are other people saying about ABA? What is the controversy that's out there? One of the things that you will notice in some of the medical necessity guidelines is you'll see all this coverage and then you'll see this, but low-VOS is not covered, or low-VOS therapy is not covered. You'll see it written multiple different ways. And oftentimes that's coming from a review of some of the controversy. And I'm not gonna get into the detail of that, but just understand when you see those kind of random things, that's because the health plan has to acknowledge that there was controversy there in one component or another. They have to look at variations in care. So dosage, types of administration, location of services. They have to look at cost, they have to look at quality, they have to look at the research that's available to them, which is great in early intervention, but as we know as a field, we do have limitations in our own research as individuals begin to age or across populations. So our research is very strong in autism and IDD, but is weaker in areas of other diagnoses such as Down syndrome or other genetic and metabolic disorders, where we know our services can be beneficial. The effectiveness in the research is not as glaring to the health plans. And then, health plans are looking at population health. And so they do have to understand, how does this impact an entire population? So not just little Johnny, which is very difficult for us because we're working with little Johnny and we're looking at little Johnny's impact. And they have to, when they write these guidelines, they have to look at the impact of the entire population. Now, again, through the appeals process, you can start to narrow that down to the impact to little Johnny. But in these initial criteria and coverage of policies, these are all of the things that they have to look at. So how is medical necessity defined? Well, first, it is defined as being for the purpose of evaluating, diagnosing, or treating an illness, injury, disease, or its symptoms. Okay, and this is something that's extremely important because in the educational world, we work on some academic supports, we work on classroom supports, we work on specific classroom behaviors, we work on problem behaviors related to the classroom. There's a lot of things that in behavior analysis that we look at as available to be treated because we know how the environment and behavior interact with one another, right? But what they're looking at paying for are only those that are consistent with the symptomology of the disease. And so if it's not consistent with the actual diagnostic criteria of autism, they actually aren't the ones responsible for paying for it, because medical necessity is falling under that symptomology. Fortunately for us, autism is a very broad spectrum, and so there's a lot of ways that we can justify some of those things as falling under the symptomology of the disease. It does have to be in accordance with accepted standards of practice, clinically appropriate. These are not going to be new things to you guys. It cannot be for the primary convenience or fiscal benefit of the patient, provider, or clinician, which I chuckle when I say this because I know that, again, fiscal benefit for a health plan versus a patient are two very different topics, but that is important to understand as part of medical necessity. Then, what becomes interesting is this very last line that seems to somewhat contradict the one before, and that's that it has to be cost effective and efficient. And so really understanding and defining what is cost effective and why that's different from fiscal benefit is extremely important in understanding medical necessity. All right, this is the triple aim. There is a quadruple aim. I'm only going over the triple just to paint a picture of what healthcare is looking to do is to use the patient experience, so quality and satisfaction of services, to improve populations of health in an effort to reduce per capita cost of healthcare. So what does this mean for us? Well, we largely serve a lot of individual clients. And so this perspective of population health sometimes gets missed in our treatment planning and the direction that we go in our care decisions. The other thing is that the experience of care that health plans are looking at is oftentimes basic satisfaction. Is the patient happy or not? And I'll tell you that the way that it's measured in hospital systems is, it's the reoccurrence rates. So if they continue to go to that particular hospital system, then they'll measure that. In primary care, it's the referrals. So the less the number of referrals to specialty providers and to hospitals and the less visits to urgent care that you have, the higher your independent practice has in satisfaction, okay? Because that means that your patient would much rather wait for an appointment with you than go and utilize an emergency service or urgent care. And so it's the concepts of how they measure things don't necessarily fit in the same realm of how we measure services. So one of the things that, for those of you who are working on outcomes projects or looking at outcomes projects, that we have to think about is how do we take the science of what we do and kind of fit it into this triple aim? How do we ensure, because reoccurrence isn't gonna help. Obviously, we work in a line of fields where, we should be priding ourselves in services no longer being needed by us. And so looking at what outcomes are going to be specific to aiding in this reduced per capita cost of healthcare. Now, I can give you some ideas. I think feeding therapy is one that we could be leveraging hugely, or programs that involve diet and nutrition, because we have so many children, especially with autism, that have restricted food interests, that in looking at the history and the research, if we just look at the restrictions in their food in isolation, and then we look at other populations that have similar symptomology, we can pull research that starts to increase the risk of diabetes, increase the risk of depression. And so all of those things, by not being treated at younger age, actually increase per capita cost healthcare in the future. And so in our treatment planning, now I don't have the answers for all of this, but again, just trying to get us to a point of our outcome measures really have to start thinking about these reduced per capita costs of healthcare. One of the other ones that I think is a big one, and I know of a couple of organizations wanting to target this in some of their outcome measures, is maternal health. Okay, so individuals with children with autism oftentimes have high rates of mental health concerns in mothers or in parents and caregivers. Again, that's increased cost. That while we don't always in our treatment plans directly link that, in our advocacy work we have to, because we have to be showing that our services aren't just about little Johnny. Our services are about this reduction in per capita healthcare costs, which is the overarching goal of the health plan to begin with. So again, it's trying to figure out their language and trying to meet them where they are. We all are trying to get to that same place. I see the work being done, but how do we align it in such a way that it's also speaking the language of health? All right, so what is effective and cost efficient? Well, health plans are looking for the efficiency and cost effective, the efficiency and cost effectiveness when it comes to coordination of care. So how are we ensuring that we're not duplicating services? How are we ensuring that we are treating services that are truly within our scope and referring out or coordinating care with services that may not be? Oftentimes, if you've been on peer reviews and you wrote a treatment plan and you noted that the child had asthma or allergies, one of the questions you may get back is, well, have you talked to the primary care physician? Or the child might be on medication. Well, have you talked to the primary care physician? Because one of the things that they're wanting to see is that the symptoms of the comorbid diagnoses aren't necessarily or are impacting the behavior, and either way that care coordination is happening, that the care isn't happening in silos where little Johnny's getting allergy shots on Tuesdays and seeing us, the rest of the week for behavioral stuff. Now, they may not be associated to one another. I'm not implying that they all are going to be, but what the health plans are looking for is that we've ruled out and we are coordinating those benefits. And so are we making sure that we're playing nicely with the others, that we're coordinating with the others? I find in a lot of presentations around care coordination, we're doing a very good job talking about behavior analysis and speech and OT and physical therapy and how we all integrate. The one piece that I continue to see as an area that we are falling short is that of the primary care physician. See, in the work that I did at PCH, and if you look at the research around medical homes, your primary care physician is your hub. That is your main go-to. All these other services are auxiliary to that primary care physician. So if you're not reporting back to that primary care physician, then that can be problematic. Now, I've also been on the other side where we've sent stuff to primary care physicians and they don't ever respond. So please know that it's not, I understand those burdens equally as well. But again, giving the perspective of the health plan, they're really wanting to push the responsibility to this kind of integrated model of medical home care, because we know that medical home care reduces healthcare costs. And one of the other things that we have to look at in our treatment plan and in how we convey our treatment plans is investing in treatment today, critical to long-term healthcare cost reduction. And so I gave some ideas around like feeding, toileting, right? Toilet training is another one that the older an individual gets without intervention, the higher risk they are of other diseases and symptoms and problem behaviors, which all become problematic in the healthcare system because it increases those healthcare costs. So again, making sure that we're highlighting anytime that we can in our treatment plans that we're identifying targets that have a specific link to reduction in future healthcare costs. Now, I don't mean going in and do your treatment plans and saying like, I'm going to do work on X goal because 10 years from now, you're not going to have to pay for hospitalization, because we obviously can't predict that. But if we understand that, especially going into the appeals process, there's a lot of research that isn't behavior analytic that we can pull into our arguments specific to those comorbid conditions that are and can be treated effectively with behavior therapy. So behavior analysis. And then we do have to look at, can it be sustained if applied across entire populations? And so if our treatments are now our protocols can be specific, but if our programs are so difficult to implement and difficult to apply across multiple populations, especially in the Medicaid plans, you'll start to see restrictions around some of those things. And that's because they're having to, again, address an entire population and not just specific individuals. Now, again, at that level, that is guidelines, and you can appeal and contest for individual basis, which again, under our ethics and advocating for the client, we do have a right to do. I'm just giving kind of that background knowledge of that perspective of the health plan. All right, so I mentioned the then fiscal budget. So this is how we ensure things are cost effective. We know it can be applied across multiple populations, that it's not so expensive and so difficult to implement that we can't do it across whole populations. We know that if we invest in it today, we're going to see a reduction in future healthcare cost needs. We're supporting the coordination of care. We're participating in the coordination of care. That addresses cost effectiveness. Now, talk about the fiscal benefits. So The medical necessity does prevent or prohibit the ability for any one party, whether it's the patient, the consumer, or the provider, or the health plan, from having any type of fiscal benefit in the policies that they write. Now, there are two large guidelines or two large laws that do support us in this. One is the Mental Health Parity Act. I'm not going to go in huge detail about these because there's a lot of other information out there about them if you're not already familiar with them, but just understanding that there's a federal law that restricts plans from denying or limiting mental health services that are less favorable than allowable surgical and medical benefits is how it's defined. So this would be imposing annual and lifetime benefits that are less favorable, those sorts of things. So that's, again, kind of a separate topic, but keep in mind that that is there to kind of protect the fiscal benefit to prohibit the fiscal benefit of the health plan. The other one that I'm seeing more and more of, and it excites me because this was the one that we leveraged in Arizona to get the Medicaid plan in Arizona to cover, is that there's also the Medicaid requirement that comprehensive preventative care be provided to children at risk of developmental delay. And so again, when we're thinking about reduction in healthcare cost and preventative care, a lot of the work that we're already doing is already to address that. I just am not sure that we're clearly connecting the dots and articulating that to the health plans. So when the health plan says, well, you can't really work on that because that's not a delay of the child right now, or mom and dad could be working on that, I'm really being able to articulate under the EPSDT service requirements that this is a preventative care procedure is extremely important, again, in the appeals process as well. And this actually, for public health plans, so your state plans, this does require treatment of at-risk as well, so not just individuals with a diagnosis. And I will say, though, with this, that ABA is not required. The EPSDT can be services proven evidence by what the public health plan deems appropriate. So it doesn't necessarily mean that every state is required to provide ABA services. But what we did here in Arizona was we took exactly this and we said, what better evidence base do you have than ABA? And we were able to push some legislation and rules and policies and stuff around ABA coverage here in Arizona using this language. All right. So I mentioned earlier that in medical necessity, we're looking at the clinical appropriateness and standards of care. This is all very, very, very probably information that you guys are used to seeing. It's something that's available to us in our standards of care practice guidelines. What we have to be able to justify to insurance is that we do have the research specific to the type, frequency, extent, location, duration of services. Now, one of the things that I will say about the duration as it comes to dosages, and something to keep in mind, a lot of people will say, well, we have the research that says that, you know, little Johnny needs 30 hours a week, but insurance is capping us at 25. Keep in mind that a lot of our research is kind of broad ranges. And so when you read the research, it's not saying, hey, this participant had 27.25 hours per week this many weeks and 22 hours per week this many weeks. It's kind of this range. And so it makes it very difficult for us to kind of navigate the precision and dosage requirements that the health plans are looking for when we can't have precision because the nature of our science requires us to calibrate care. And so that is kind of a challenge that we're going to continue to be up against, that this idea of health plans saying that, you know, you have to have a certain number or you can't have a certain number is challenging because we don't have the evidence to say one way or another, because everything that we have is calibrated in the moment based, you know, on the circumstances, environment, and the client that we're serving at that specific time. So it can be very challenging. But I think the biggest take home that we have to keep in mind when it comes to medical necessity is that health plans are only paying for the treatment of the disease. Okay, so they're not there to pay for other considerations. And so in order for us to align with the treatment of the disease, we have to be coordinating with the diagnosing provider and all of the other care providers, because we have to be treating the symptomology and not necessarily just running ABLS and BB-MAP and treating what the scores on that assessment is pulling for us. For standards of care, if you guys have not seen this, hopefully you have. BACB has a beautiful document that outlines kind of our best practice standards of care. It is produced for health plans to understand this. Again, we're looking at ranges and dosages, which is part of the problem in getting certain dosages approved. All right, real quick, let's go through some treatment planning considerations. So we know this about ABA. We know that we start with an assessment, we have treatment planning, we start to implement the treatment, we have ongoing data analysis, and then we have treatment modification, and then we return back to assessment. So this, again, is nothing super new, but a couple of things that I want to, again, reiterate going into this is that as we move through this process, our primary goal has to be for the purpose of treating the actual diagnosis symptomology. Okay, so we are here in billing medical companies, we are here to actually treat the symptoms of autism. So in order to do that, we do have to develop plans that support the diagnostic finding. So again, if someone comes to me and says, hey, Tony has autism, can you provide these services? And I just, run a BB-MAP, or I just do an FBA, and I'm not looking at any of the diagnostic findings specific to the condition, that can be problematic. So I do need to make sure that I am doing a thorough review. The records review should include a review of the diagnostic summary. Now, one of the things that there isn't a standard out for, but a lot of people will ask me, how old should the diagnosis be? So in some states, it's required that children are reevaluated annually by a psychologist or an approved diagnostician. And that, I think, is a little bit excessive. For me, I like to, for my own practice, I like to kind of use the 5-year rule, that if you're approaching 4 or 5 years and you haven't been seen by a psychologist, or you haven't had any other diagnostic evaluations done, it's probably a good time to kind of revisit that. And one of the reasons why I do that is because when we look at child development, those kind of 4 and 5 year marks are really important years in a child's development. So the entrance into kindergarten, the entrance into junior high, the onset of puberty, transition planning, exiting school and going into adulthood. And so all of those things, their environment changes, and we may see other symptomology that requires some sort of intervention. And so for me, I kind of use that as the guideline. There isn't a huge standard. I know some health plans do 2 or 3 years. I think 3 years is okay. I think 1 or 2 years, you're not going to see kind of the results that you'd be looking at. But those major milestones in development, I think it's very important to have a clear understanding as a clinician of what the diagnostic makeup of that individual is. Now, with that being said, there are times in which you will, send a child, they'll have an entire diagnostic evaluation, and maybe repetitive behavior doesn't show up in the summary report, but you work with that child every day and you know that it occurs, or you know that the parents are sensitive about it, so they probably didn't report it. It doesn't mean you wouldn't provide treatment to that. It just means that you have to account for that discrepancy and making sure that you're utilizing that information. I'm a big fan of standardized assessments, not for the purpose of planning treatment, but for a pre-treatment baseline. Sometimes we just jump in and we start providing services, or again, we're using a curriculum referenced assessment and we don't have a true pre-treatment baseline. If that's already been done, so I work a lot in early intervention. So if I have a psychologist that just did a panel of standardized tests for diagnostic evaluation, child receives an autism diagnosis, comes to me, and all that testing was done 3 months ago, I'm not going to redo any standardized assessment. I will use that as my kind of pre-treatment baseline. But the standardized assessment allows for me to monitor the treatment that I have. And then we also have to identify those comorbid medical risks, document their role, if any, in treatment, and ensure that we're already planning coordination of care. One of the things that with coordination of care I find is that oftentimes it's documented in the treatment plans because in the audits or in the health plan reviews, they tell you to put it in there. So a lot of plans have this kind of standard, like, we will coordinate care, or the parents can reach out to us if they would like for us to coordinate care. One of the things that I have found to be helpful is being specific in that coordination of care and documenting. I faxed a copy of the treatment plan to the primary care physician on such date. I, oversaw the speech, or I observed the speech therapy session on such and such date. So making sure that we're documenting kind of that coordination of care. I attended a planning meeting. I did this just to show that that's present. And the other tip that I would give in the treatment planning is making sure that your outcomes clearly identify the remediation of the autism criteria, so that you're not just writing outcomes just based on the ABLES and BMAP. Use them, I love them. I'm not saying don't use them, but make sure that you can clearly identify how those specific outcomes would remediate the symptomology of the actual diagnosis. I've kind of gone over this a little bit for the sake of time. You guys will have access to this slide, so just keep in mind that coordination of care is two-way conversations, not just a blanket, hey, I'm willing to coordinate care if I want to. That truly, if you're counting it as coordinated care, there should be a two-way conversation. There should be a family-centered approach. There should be an inclusion of all stakeholders in planning meetings. And that we should always be consulting with specialists and subject matter experts, and we should be documenting that. That's one of our ethical requirements as well. But again, I see a lot of AAC device training programs, PECS programs, what have you, with no coordination of care with the speech pathologist or another speech pathologist that is well qualified or trained to provide that consultation. I highly recommend that you consider documenting these times in which you're utilizing this, because all of this counts as coordination of care. Making sure that when you're formatting your treatment plans, you can do it multiple ways, but that, again, you're identifying the social communication, social interaction, and those restricted repetitive patterns of behavior, interests, or activities, and that the outcomes that you are linking to those specifically meet that criteria. Some examples that you might want to use is starting them off with to remediate deficits in social emotional reciprocity as you start, to introduce some of your goals or what have you, so that the health plan's clearly hearing that diagnostic piece in your treatment planning. One of the things that I look at in dosage, and this is kind of a little document that, or a little flow chart that I had put together, all based on the BACB's health plan document. It's nothing new, nothing I came up with totally on my own. But I like this vision because it allows for me to kind of bucket my dosage recommendations. So we know that early intervention is designed to target gains in developmental trajectory, which is important to differentiate from other comprehensive programming, because my outcomes and the results of the treatment have to match that as well. So an example might be if I'm doing comprehensive ABA for a 14-year-old with severe autism, nonverbal, significant problem behaviors, maybe not toilet trained, significant feeding issues, I may still be running a comprehensive ABA program, but the outcome measures that I have are going to differ greatly than that of a 2-year-old that I'm providing EIBI services for. And so that's very important distinction in your progress monitoring to keep in mind, and in how we develop our goals. The other thing that I like to use this with is the number of goals that I'm writing. So I may be saying, hey, you know what, I'm going to do a focused program. We know that that's going to be between 10 to 20 hours a week. If we're going to do 10 hours a week, how many goals are even reasonable? And making sure that all of my recommendations kind of go back to these blanketed kind of buckets of recommendations that are available. What I oftentimes see when I do plan reviews is, treatment plans that are recommending 10 hours a week but have 25 goals. Well, it's very difficult to monitor progress, to implement treatment, to implement treatment to fidelity when you're only there 10 hours a week. And so really getting the treatment plan kind of fine-tuned to match the characteristics of what type of program you're running is important. Likewise, I see comprehensive ABA programs come out with recommendations 35 hours a week and 5 goals. and no parent training goals. And that becomes problematic because, again, our own kind of description of these services have key characteristics that we should be aligning. One of the things that I do get a big question on oftentimes is, what if our recommendation is comprehensive ABA and the family's like, look, all I can do is 15 hours a week and that's it. Then I would shift the entire trajectory of your treatment plan, if it's applicable for the child, and move into a focused ABA. Prioritize your goals, decrease the amount of targets that you have, shift your target in the treatment plan, and make sure that you're aligning your treatment plans with your dose recommendations in every facet possible, that you're not just arbitrarily throwing a dosage amount out there without clearly being able to articulate how you're going to utilize those hours and why, and how that aligns with the best practice standards. Other things to keep in mind, it is very important that we are focusing on responsivity to treatment. So I do get a lot of questions around, hey, I've been working with little Johnny for 4 years. He's now 8. Insurance wants us to cut down to 15 hours a week. I still think he needs 25. One of the problems we run into is our own research doesn't extend beyond comprehensive programming after 2 to 3 years. And so it becomes very challenging to convince an insurance company to continue to run at high levels of dosage when we're running into potential responsivity to treatment concerns. There may be learning barriers, they may be environmental barriers, they may be programming barriers. Sometimes, you know, one of the biggest, and this is probably more of my own professional rant, one of my biggest concerns around dual relationships is if you have been provided comprehensive care beyond that, 3-year mark that our services, recommend, you're still recommending comprehensive care because you've been their BCBA for 6 years. Sometimes the barrier itself that you need to identify is potentially your own treatment. And that's a very hard conclusion for us to kind of to get to, but I encourage you to think about, like, our research for comprehensive care is 2 to 3 years of those comprehensive programs. And so again, at 6, 7, 8 years, responsivity to treatment is a concern the health plan should have because they have to address abuse and waste concerns. Keeping in mind all of these other components that our research talks about, age at the onset of treatment is documented in research, so our outcomes are better if the child onset of treatment is before 7. They become, especially in comprehensive intensive services, the outcomes become less optimal. Doesn't mean they're not there, but they're less optimal above the age of 7. Length of treatments well documented in research, social determinants of health. So those sorts of things are other things that we have to consider when we're making dosage recommendations. In our monitoring of treatment, again, pretty basic stuff, but things we have to keep in mind is, how are we utilizing the hours? What does that look like? Are we using the hours? So if we're recommending 25 a week, but on average we're only using 18, do we need 25? Do we need to change the program, or are we comfortable with, recommending 20 or less, or what have you? What is our visual representation of the treatment effectiveness? What are the learn gain scores? Again, in some of the programs that I've seen that have kind of 6 years worth of comprehensive ABA services, and the family's still advocating for more, and the BCBA is still advocating for more, and then I come in and I look at it, these kids are mastering maybe 2 or 3 goals a year. That kind of goes against our own science. And again, that makes me wonder if there's some fidelity concerns with the actual program development and program implementation itself. And so those are all things that we should be thinking about. Now, I have IQ test in here, not because I think about it or I run it or I understand it, but because research does mention the IQ testing. So don't be surprised if health plans also request or mention it as well. All right, so I want to leave, I know I kind of rushed through some of that. Like I said, I have about 4 webinars worth of information on all of this, but I want to just leave you guys with a couple of thoughts. One, insurance companies are starting to move towards value-based purchasing. This means as a field, we really have to understand large-scale outcome measures. We also need to think about our own research limitations, and I empower you to continue to research if you can. If you have relationships with universities, or you have the ability to to continue to produce research, we need it. We especially need it in community settings. A lot of the research that is referenced in the medical necessity guidelines are clinic-based under very contrived settings, and that happens to be a very large limitation for us. Also, the dosage ranges are a limitation for us. And again, this isn't me trying to say, oh, here's all the things we're doing wrong. What I'm trying to do is employ you to kind of explore the research opportunities that are available. Population sizes, population demographics. So, one of the reasons why insurance companies cover autism services is because there's 3,000 plus research articles to support it. So if you are working with other populations or you are working with young adults, really keeping in mind the role of research in being able to move the needle in some of this medical necessity stuff is huge. And so please don't lose sight of that. And the other thing that I think we need to think about is the priorities as far as us in behavior analysis wanting to make meaningful behavior change in kind of isolated settings. Like if we've changed one person's life, we're really happy with that. Health plans are dealing with large populations, and so we have to keep that in mind. And we also have to keep in mind that at the end of the day, health plans are still businesses, as are many of us. And so money is a part of the game, and we have to be able to articulate priorities appropriately while also balancing our requirements to advocate for our clients. And then I leave you with, kind of this thought that comes to mind often for me is when I really think about utilization review and pre-authorization, knowing both sides of the coin, I really don't think that we're that far off from one another. I think there's a complex language barrier that lies between the managed care organizations and the treating providers. And so the more that we can learn their language, speak their language, and crosswalk their language, the better off I think we're going to be. Because the more that I've dove into it, the more that I see they're really not that far off from our own principles and standards and requirements. And best standard practice and what's expected of us in our ethics. And so I think it's just a matter of fine-tuning our treatment plans, being honest with ourselves in fidelity and integrity concerns that are present, being very true and honest and consistent with the research, understanding those research limitations, and then from there, learning their language so that we can crosswalk the rest. All right, that was a lot, but questions?
Thank you so much. That was so much wonderful information right there. I'm not seeing any questions in our chat or our Q&A, but I would welcome our attendees to let us know there if they have any questions or concerns or anything that they'd like to follow up with. All right, so Danielle says, do you have any thoughts on MUEs, medically?
Unnecessary
edits. Yes, right.
Yeah, good job. I support the work that has been done with the current steering committee to adjust the MUEs. Which should have gone into effect April 1st. I know that there was a hiccup with the MUEs and I know that they have been frustrating, but I do think that the recommendations that APBA and ABAI and kind of that steering group for the CPT codes have made that CMS adopted, I would support those. The MUEs are again, not behavior analysis specific. MUEs are present across all treating providers, and many other clinicians and medical professionals run into issues with some of them. All right, so Pamela's, you know what, it's not letting me scroll up to.
Okay. So Pamela's, I'll put hers together. So are insurance providers required to coordinate with each other for dual coverage where one approves 40 and the other approves 20?
Are you referring to like primary and secondary, where if you had a primary insurance that says, hey, we will only do 20, but secondary policy says we'll do 40? most states, and I say most states because if you live in a state that may be different, and you can always email me, most states and in most policies, primary always trumps secondary. And the way that they do that is that secondary says that they have kind of a blanket, we accept primary recommendations. And so basically, if you know that, and we do this, see this in Arizona, where I know I can take a child to a child that is primary Medicaid. In other words, they don't have any other insurance. Medicaid is their only insurance. And our Medicaid program here in Arizona doesn't require pre-auth. So let's say I've got a 3-year-old, I've got justification for 40 hours a week. I can take them in for 40 hours a week. But let's say I've got another 3-year-old who is Aetna as primary, but Medicaid is secondary. Medicaid only covers what primary doesn't under medical necessity, but their medical necessity is going to default to primary's interpretation of medical necessity. So in other words, that if Aetna says, nope, 25 is the max you're gonna get, they don't make up the difference of, well, little Johnny got 40, that they say, well, Aetna is the one that determines medical necessity. We support secondary on claims. So I've never had a state that has had language different, but it's possible. So I'm happy if you want to shoot me an email, I'm happy to look into your state Medicaid policies. But generally speaking, the Medicaid policy recognizes the medical necessity of the primary. So if primary says 25, Medicaid honors 25.
Makes sense, makes sense. All right, so another question is from Paul. Do you have any recommendations for large scale outcome measurements? For example, any specific tools that are widely accepted by health plans?
I do not. No, Paul, there's a lot of work that is being done and continues to need to be done here. There's a lot of controversy around the current standardized testing. So whether the PDDBI is appropriate, whether it should be the ADOS, whether it should be Vineland, and each plan is still defining that separately. More of those large scale, so those long-term outcomes have not really been developed by our field yet. There are several interest groups that are interested in tackling that. It's extremely important under value-based purchasing because value-based purchasing is starting to kind of merge in the Medicaid plans nationwide. And the problem that we're running into is that all of that is based around specialty provider referrals and hospital readmissions. And so we kind of don't fit into either one of those. And so those big outcome measures, I would keep an eye out for work that that any of your interest groups, APBA, BHCOE, any of those groups you're a part of are working on, because it is coming out as work, and I'm sure there will be work groups that will be coming of it. So I would just kind of keep an ear out, but there are none at this point.
Yeah, that's absolutely an important thing that a lot of us are working on right now. And from our Q&A and related to what you just mentioned, can you elaborate on what value-based purchasing is and how it impacts care?
Yes. So value-based purchasing is a concept in which the health plans incentivize quality. And the way that they do it is by contracts that are not fee for schedule. So what we're used to is those fee for schedule, like for every hour you get X amount of dollars. And instead it's for however many patients you see and make X progress with, you get a kind of a bulk payment for. And kind of the idea that value-based purchasing is heavy right now in primary care. And the reason being is because primary care doctors, and I'm sure you're familiar with it, you see them for about 15 minutes, but their codes are all half-hour or hour codes. So they get to that like 16-minute mark where they can bill the full half hour, and then they're gone and they're seeing other patients. And what they're finding is that health plans are spending a lot of money on specialty referral providers and on hospital readmissions because the doctors aren't spending enough time with the patients. And so this value-based purchasing there's several, they're called federal medical health homes that are already operating under these, is under the premise of paying for outcomes instead of paying for hours. And so the concept itself is really cool. The more you learn about it, the more you're like, oh, that's kind of, behavior analytic, right? Like we're going to pay for, we're going to provide reinforcement, based on specific behavior anchors versus just how many versus quality, right? And so that's kind of the premise of value-based purchasing, is this idea of paying for outcomes over hours. And that's the easiest way for me to describe it. Again, the problem with that is that our line of services do not really fit in the way that the contracts are currently interpreting it. And there's two sides to that. One is at one point there was a scare that some states were going to move to value-based purchasing only, which would be very problematic when we don't have the mechanisms to support it as a field. But then a lot of states have now kind of have this opt-in program, or if you have federal contracts, there's kind of an opt-in for it. And for me personally, it'd be really cool if we had the right measures to use our own science to kind of drive the quality of care. Per member per month payment is kind of an easy way to describe it. Yep. And that amount of the payment would be on a scale based on your quality. But it's so that you no longer have to worry about getting your hours in, and you can focus on what does the child really need. And that's how Canada, I know there's a lot of political controversy right now going on in Canada, but that's how Canada historically has ran their ABA programs, is you get an amount of money per member per month, and you do whatever you need with it. And what happens with that is if you get an amount per member per month and you have one member that doesn't need all of it, it's kind of like IEPs, right? Then you can allocate the funds accordingly to make sure holistically the entire population is getting what they need. Your entire population base is getting what they need. And you can budget accordingly versus that hour per hour.
Great. Thank you for that. We have, I'm looking at Danielle's question, which is a wonderful one. I hear this too. Do you have suggestions on advocating for treatment of adaptive skills, such as teeth brushing, when the payer says they will not cover that treatment as it is not a core deficit of ASD?
Yeah, it's hard. One of the things that I look at is, looking at the function of why the skill isn't present. And seeing if you can identify symptomology that aligns based on that function. So for example, if brushing of the teeth is oftentimes for our kids, it's an avoidance, and oftentimes an avoidance of some sort of negative or painful stimuli or what have you, that you articulate a goal that matches more of that component, and then you use the teeth brushing as a strategy towards that goal. So rather than writing a goal on teeth brushing, you write a goal on why the teeth brushing is not happening, and then use the teeth brushing as as one of the teaching strategies to address the goal.
Wow, that makes sense. Clever. All right.
I think Pamela had one more with the Muse.
Mm-hmm.
Respond partial denial. TRICARE, where the max MUE for protocol mod is 2 hours and the treatment plan requested increased MUEs does the insurer have to respond with partial denial if they want to approve the requested increase? I'm not sure I'm following the question, Pamela. So you're requesting more than the 2 hours per day on a protocol modification? Okay. In general, the MUEs are very difficult even against an appeal to kind of go against, and the MUEs are actually set by CMS and not TRICARE. And so the problem is that if they adopt the MUEs of CMS, CMS is kind of like the mama bear of all of it. And so trying to get above the 2 hours per day. Okay. But the protocol modification for, I'll have to look at it. I don't bill TRICARE, but well, then you can appeal and fight for the CMS MUEs. They don't owe you a denial though. One of the things that's unique about TRICARE is it is also a federal plan, and it is actually still considered a pilot program, which is why you guys see all the fluctuations in it so much, is because it's still kind of under a court-ordered kind of investigative process. It's still considered a pilot program. So you'll see all that fluctuations. But I can take a look. Yeah, Pamela, if you want to email me, I can take a look at that.
All right, thank you. And I'm gonna pose one last question before I let you go. I know that your time is valuable, so I don't want to keep going too long. But Selma on Q&A says she's running into a brick wall about this one. CMS doesn't list a rate for ABA codes. How do they find out the amount allowed?
For your health plans that are commercial, they should be putting that in your contracts, and you can negotiate that. And I know BHCOE has some negotiation webinars that they've done in the past. For Medicaid in general, all Medicaid policies have, and I can't at the tip of my tongue remember exactly what it's called, but there is a policy out there that is basically blanket rate. So in Arizona, our blanket rate is 58.67% of the billed rate, meaning that if I bill Blue Cross Blue Shield $100 and they say, hey, the patient owes the $100 because it's going towards their deductible, I can only bill their secondary Medicaid $58.67. Because the Medicaid rate is a specific percentage of the allowable amount. This is where, as behavior analysts, we ran into some issues, is that what happens when Medicaid's primary and you're trying to bill those new codes, and what is that rate? Well, some states have licensing laws that require facilities to post their rates. You might in your handbook have like an arbitrary, like, our services are $100 an hour. And if that's what's in your handbook, then you're going to bill Medicaid that percentage of that $100 an hour, because that's what your facility and best practice and all that stuff's coming from. So ideally, if you are one of those businesses, you've worked with the CPA to establish a rate that is feasible and beneficial for your operations. But exactly I know where to find it in Arizona, of course, but what you'll want to do is look on the Medicaid website and look for it's a little percent, it's like a percentage of, and it might be under billing, like any of their billing resources, or you can call them and ask them and say, hey, you have a code that doesn't have a rate. Can you tell me what percent you cover? And they should be able to give you that information. If you want to shoot me an email, I can pull the exact verbiage that Arizona uses, and you can use that. But in Arizona, it's 58.67%. And we don't even have to really know that. So in other words, if I bill $100, they're only going to cover that 58.67%. Now, obviously, if you are if you're looking at going in network with one of their providers, and that's one of the citing factors, even though they haven't set rates with Medicaid, you can still encourage the actual MCO to provide you with rates. And so that's what some of the organizations have done out here, is they've said, well, we won't go in network if you don't give us rates, and they've kind of forced the MCO to designate a rate. Danielle, MUEs should be specific to the bill code. So you shouldn't run into that. Absolutely. You shouldn't run into that.
Okay.
Selma has one more question. I can answer it real quick. Sorry.
Yeah, go ahead.
Selma, I don't know it offhand, but there is a taxonomy code for RBTs and BCBAs. You can Google it and it'll pull up both of them for you. What you want to do is check your contract and see if they're wanting the taxonomy code for the BCBA and the RBT, or just the rendering BCBA, or just the RBT. And that's going to be contract specific. Yeah, you'll still want to check with Medicaid's billing because it's their billing system. Thank you, Brian. Yeah, that's a billing system specific issue with the CBT. Oh, well, your state may not cover it. Are you sure your state covers ABA services? What state are you in? And keep in mind that pre-auth is not a guaranteed coverage of payment.
No, Magellan.
Interesting. That's one of the problems with CMS not valuing the codes, is it's kind of made a mess of everything. I would go back and look at your contract and double check that. I would double check that that's written in your contract. Yeah. And it doesn't surprise me, because I really do think that doing 7 hours of therapy, plus the 1 hour of supervision, which can be done simultaneously, is a lot for one family. And so when we look at the principle of medical necessity also needing to meet family-centered care, it is possible. I could see it being possible that people would want to max on that under that principle, medical necessity. And Selma, I would just double check that your Medicaid plan covers the services, and that you are in network appropriately with them. It might be a specific contract issue. All right.
Okay. All right. Well, thank you so much, Diana, for helping us out by delivering this webinar for us. It looks like folks were still have a couple of questions here and there coming in. And we so appreciate you coming in and doing this for us today.